All for joining us here today. We're excited about kind of continuing the Rural Health Association educational webinar series. This is something that we have wanted to do for a little bit, and so we were able to kick this off this year. And so far we've done um, building resilient leadership teams in rural healthcare. Today we have Joe Ebberwein. Am I saying that right? Ebberwein.
Yeah,
Ebberwein.
everyone. No, you
Ebberwein.
got it.
I've
First
known
time.
Joe
Yes.
for a long time. I've just always called him Joe. So he's with Corstrata, and then we have Alicia, who is with Strategic Health Partners. That's correct, right?
No, Alicia actually is our VP of
Is
clinical
your
for
VP?
Corstrata.
Okay. All right. Good deal.
Yes,
Is Mike on? Oh, I see Mike there, I think. So
Mike's
How you
on.
doing? How you doing?
yeah, Mike with Strategic Health Partners. So anyway, so just talked with Joe here a while back, and we kind of feel like this is something that is much needed. I've been in the telehealth space, as many of you who know me for a while, 15 years in telemedicine with the Georgia Partnership for Telehealth. 10 of those years as the executive director for the Southeastern Telehealth Resource Center. I am now also, the executive director for the Georgia Rural Health Association. I do want to take just a second and plug the conference that's going to be coming up in September. That's our annual Georgia Rural Health Association conference. It's September the 17th through the 19th. That's going to be a half a day Wednesday, full day Thursday. Thursday will be more breakout sessions, and then half a day on Friday. That conference is going to be at the King and Prince on St. Simon's Island this year. We're starting to push up a little bit close to our early bird registration deadline. So, if you feel like it's something you are interested in, I encourage you to go ahead and register for that. I'm going to post some information about that here in just a couple of minutes. But really, without further delay, I'm going to turn it over to you, Joe and Alicia and Mike, and I will let you guys take over from here.
Sounds great. Thanks so much, Lloyd. It's great to be with everybody today. As Lloyd said, I'm Joe Ebberwein. I'm co-founder and CFO at Corstrata, and you'll learn more about what we're doing at Corstrata. But we're excited to be here with GRHA today, really to explore a challenge that we see across the nation, and it's especially critical to rural communities, and that's wound and ostomy care. And we're going to talk a little bit about how our virtual model can help you in a number of ways, improve clinical outcomes, potentially reclaim lost revenue, and really strengthen the hospital's role in the community as a wound care center, a center of excellence. So I want to introduce Alicia Jenkins. Alicia, if you'll introduce yourself, and then Mike from Strategic Healthcare Partners.
Certainly. Thanks, Joe. Hello, I'm Alicia Jenkins, and I'm Vice President of Clinical Operations and Partnership Success at Corstrata. And I work with our team of amazing WOC nurses. I've been a wound nurse for over 25 years with experience across acute and post-acute settings, from home health hospice, hospitals, skilled nurse facilities, really wherever you need a wound nurse. And I've been certified since 1999, really with a long time focus on both clinical and the economic impact of wound care. I began incorporating telehealth into my wound care practice back in 2008.
In Tennessee.
Hold on just a second. Hey, if
Yeah.
everybody can, please make sure that you have yourself muted. That way it just kind of eliminates background noise. Sorry about that. Go ahead, and Alicia.
No worries. So I've really been able to see firsthand how virtual care can really improve access, outcomes, and efficiency across care settings. Joined Corstrata in 2021 and have worked with the team to build scalable, evidence-based virtual wound and ostomy programs that support providers across care settings and align with value-based goals. So turn it over to Mike to introduce himself.
Yeah, thank you, Alicia. Mike Scribner. I'm one of the partners with Strategic Health Partners. We are a managed care and financial analytical firm that helps mostly rural providers and mostly in the state of Georgia. So hospitals, smaller practices, rural practices, FQs, et cetera, et cetera. That's kind of our world, is the smaller providers out there. And so love the opportunity to talk to you guys today, and really, really enjoy the conversation, the relationship with Corstrata.
Thank you, Mike. Yeah, we're excited about this opportunity to really combine where we see incredible value, and that is not only in the clinical delivery, but also, what does the data show? How does the data support a strong wound and ostomy model? So hopefully by the end of this session, we're going to talk through the clinical and financial burdens that are associated with really poorly managed wound and ostomy patients in rural hospitals where there's really not a lot of access to expertise. We're going to talk through some real world strategies. We're going to look at how you can apply virtual specialty consults, not only to unlock new revenue streams, but also potentially reduce transfers. And then we've also, hopefully, we'll have some time to talk through some of the funding opportunities as it's related to telehealth. So, Alicia, I'll turn it over to you.
Yeah, so just a little bit about who we are. We are a national team of board certified WOC nurses, and we have treated over 40,000 wounds virtually to date. And we've seen over 3,500 ostomy patients and provided recommendations and consults to them. Our nurses are licensed in all 50 states and supported by an organizational structure that's designed for seamless telehealth delivery. And we do provide that expert wound and ostomy care in a variety of settings, including acute and post-acute care from home health, skilled nurse facilities, hospice, and long-term. Hospital at home programs as well. I'm sure you've heard about those, one of the fastest growing service areas. And no matter the setting, we partner with your teams to deliver that expert care and improve clinical and financial outcomes. So just a little bit about the different settings. Obviously, anywhere where a patient's being cared for, they oftentimes do have a wound. So we do we work with the acute care hospitals and hospital at home, as I mentioned. Rural and critical access hospitals, they rarely have access to the wound specialist. And only 60% of hospitals actually have access to a WOC nurse. And then those hospitals that'll begin working with the Team Bundle, the CMS initiative that launches here in January of 26, supporting those organizations to have good outcomes. We also work in post-acute care, home health, hospice, PACE, SNFs. Somebody mentioned FQHCs a while ago, and even work with a homeless population. And then certainly other settings, either directly to the patient or with mobile physicians and primary care physicians, ACOs, in the value-based care. Studies have suggested that a quarter of hospitalized patients have some form of wound, highlighting that need for consistent wound prevention, monitoring, and specialized care strategies across the inpatient settings. And then wound prevalence, when you move to post-acute, well exceeds 30% in the long-term acute care, post-acute, and even ICUs, especially among our older adults and those with comorbidities like diabetes, immobility, and vascular disease. Our suite of services. So how we provide wound care services is either through live video consults, kind of like this, where it's a HIPAA compliant platform where we are able to provide that assessment, the documentation, the recommendations. Oftentimes we are doing that in conjunction with an on-site clinician, or we can do it via store and forward or asynchronous, where they're providing us wound images and pertinent information like an H&P that would have meds, comorbidities, allergies, things that would need to be taken into consideration for those wound recommendations. What are they in the hospital for or on service for? And then certainly we do wound care program design, everything from formulary just review to full revision, competencies where we help support that negative pressure wound therapy, compression, or other competencies, and then development of guidelines for organizations as needed. We provide educational services, both patient education, of course, that are provided through consults, as well as we do a lot of clinical education from paramedics, CNAs, RNs, providers on wound care. And then comprehensive wound management. We can do everything from a one-off consult as needed to establish that initial plan of care and treatment modalities to comprehensive wound management, where we're following that patient to full wound closure and making recommendations even after at closure to prevent the recidivism that can be so common in, especially your pressure injuries or venous leg ulcers.
And I would just add that really one of the things, and we've been doing this for about 10 years now, one of the things that we learned early on is that providers really want an easy way to communicate. They don't want multiple apps to sign in and out of. The bedside nurse needs to easily send us a consult. So we've worked really hard on basically being able to do that with a HIPAA compliant web form, not a different sign in or any of that. So really reducing the friction in being able to work with our experts.
Absolutely, that is so important. And then we work in over 35 hospital locations within 16 states. So we're a really proud provider and partner with the growing hospital at home movement, supporting many organizations. And they chose Corstrata for our expertise because of those board certified WOC nurses to deliver that specialized wound and ostomy care. And then for our scalability, we can meet the needs of whether it's a small organization or a very large multi-state program with that consistent high quality care. And then for our partnership, as we integrate, like Joe was just saying, seamlessly with their teams to improve the outcomes and patient satisfaction. So really working, when you choose Corstrata, to join a network of leading hospital at home providers that trust us to deliver results.
And speaking of results.
And speaking of results, yes, rural hospitals really need solutions that not only improve the patient outcomes, but also just make financial sense. And as you can see here, Corstrata delivers that measurable impact in both wound and ostomy management. When you're looking at that 30% reduction in wound healing time, we also see that about 30% of the time, wound etiology is not identified accurately. And that's really pretty much going from acute care to post-acute care that is commonly seen, as well as 50% of the time a pressure injury is not staged accurately. And if you don't have that accurate etiology or staging, you're really not driving that evidence-based treatment plan. So that accurate diagnosis really leads to that appropriate treatment, the improved healing rates, and it also, of course, reduces your liability risk, both from an audit as well as legal perspective. And of course, patient satisfaction is at the core of what we do. So you can see that with our high net promoter score. Really not seeking to just be an added service, but to really improve your outcomes, the patient outcomes, cost efficiency, and that clinical excellence.
I would just add also that what we hear a lot is that when we become involved with our clients, the nurses at the bedside feel a lot more confident, not only in their care, but also their ability to identify the wounds, come up with a treatment plan. The reduction in nurse utilization is important because if Alicia and her team can recommend a more advanced dressing that allows for longer wear time, then it reduces the number of dressing changes and gives the nurses back some of their time and productivity as well.
Absolutely.
So, the problem that we're dealing with is nationwide, and it's growing. The number of certified nurses in wound and ostomy care is declining as some of the older certified nurses retire. So right now, there's about one certified nurse for every over 1,000 patients, and that is even more acutely present in rural communities where there really is often a lack of access to expertise. About 75% of the wounds are improperly managed, and part of that is, as Alicia said, if you don't identify the wound properly at admission, then you're going to have downstream effects from that. Coding is a really big deal. Again, not only from the standpoint of accuracy of coding of the wound type or etiology, but also the staging of pressure injuries, which is about, we see about a 50% error rate in that area. On the ostomy side, although it's not as big a problem, there are about 1 million people in the US living with an ostomy, about 130,000 new ostomy surgeries every year. The care, either preoperatively or post-operatively, is severely lacking. So you have a really high readmission rate. And that's across the board. The 90-day readmission rate for ostomies is 38%. And the average cost of a readmission, just because of how compromised these patients are, is about 49K. 80% of those are preventable with access to expertise. And we see this all the time. We do, as Alicia said, we do a lot of ostomy consults. And a lot of times what we hear from the patient is that they never saw an ostomy nurse, even in the hospital, and really are sent home with inadequate education about how to have this whole new way of living. So ostomies are a problem, but we also think it's an opportunity, again, from that kind of center of excellence standpoint. So from the rural health standpoint, what's at stake? The data shows 1 in 4 patients in rural hospitals are mismanaged or transferred when it comes to wounds and ostomies. Medicare penalties are significant with readmissions. Across the nation, there are about 17,000 pressure injury or pressure ulcer lawsuits. You can't turn on the TV without seeing, a legal firm that's talking about loved ones' bed sores. And these can often come with upwards of 1 million, and we've seen in some cases amazingly high verdicts on the lawsuits. And then rural hospitals from the swing bed volume standpoint, and Mike's going to talk a little bit about that as well. But we really believe that failing to address this means you're losing patients, revenue, and really risking both survey issues from a documentation standpoint as well as legal exposure. But solving it protects your margin, it builds patient trust in the community, and drives the momentum, for the hospital. Um, Again, some of the hidden costs when it comes to wound and ostomy care gaps, bed capacity loss with extended length of stay for complex wound patients that may or may not even be, being treated according to the latest evidence. High nursing burden, I touched on that, just nurse confidence in wound care and ostomy care. It can often lead to excessive time related to wound care, frequent dressing changes that can lead to frustration and burnout. Missed revenue from a swing bed or an elective volume standpoint, just managing that capacity for unmanaged wound patients or swing bed eligible patients. And then we touched on the quality and compliance. So really inadequate documentation related to wound and ostomy care, as well as staging, creates risk for survey, for compliance, for billing denials, missed coding opportunities as well. So how can we turn this problem into an opportunity? And we believe with virtual wound and ostomy care, there's a big opportunity, not only in enhancing clinical confidence at the bedside, and that can be both inpatient as well as swing beds, or in an FQHC office with staff. It increases the confidence because the clinicians know that they have access to expertise in some pretty difficult, complex wounds. It also improves staging, accuracy of identification, documentation for coding and compliance. Also, really accessing educational resources. And we have a number of modules that we offer, everything from basic skin integrity that's very appropriate for CNAs up to advanced wound care, fistulas, negative pressure, palliative and hospice wounds. Um, so it's a pretty wide variety and array of educational resources to really bolster the care in the community. As far as revenue, protecting and growing revenue, a big part of it is reducing transfers, retaining and retaining patients in the local community, reducing out migration, expanding swing bed capacity with wound patients. Some are even looking, some of our customers are looking at vent programs for which wound care is a vital component, capturing new revenue streams like diabetic foot ulcer programs or ostomy clinics, and then really strengthening the marketing brand within the community as a wound ostomy center of excellence. We often work with our customers on their marketing and branding when it comes to wound and ostomy care, improving the staff and confidence and patient satisfaction. That is critical. I mean, we hear from our customers that their nursing staff, we hear it directly. I've never felt so confident managing a wound patient. And that's really extremely rewarding. There are opportunities to collaborate on rural focused policy pilots and case studies and telehealth advancement, which Lloyd and his team are always looking for, and then strengthening as far as accurate documentation as well. From the FQHC standpoint, and Mike can speak to this from his position, but there are definite preventable ED visits and hospitalizations for wounds through early intervention and adequate treatment plans, improving really chronic wound and ostomy outcomes for high risk diabetic and aging populations, and we know those are prevalent, especially in our area of the world. Integrating virtual consults into transitional care, remote patient monitoring, chronic care management, for added reimbursement. Having an expert virtually can open up potentially those revenue streams, enhancing all the quality measures and metrics that are tied to chronic care, supporting documentation. And I know we're mentioning that over and over again, but it's so critical, not only to billing, but also, and probably most especially in risk adjustment assessment and ACOs and other value-based care organizations. We have researched, because we're now working in PACE programs, and just the initial assessment of the patient and adequate documentation regarding pressure injuries and staging of those can mean upwards of 10,000 a year in reimbursement. So it is critical to have that expertise as part of the initial admission. And then partnering with hospitals for post-discharge continuity care transitions, preventing those avoidable readmissions. That's critical in the team model that's coming that Alicia talked about, and the fact that hospitals are going to be on the hook for the 30 days post-discharge is pretty innovative from a CMS standpoint, and really will be a game changer. So Alicia, I'll turn it back over to you.
Yeah, thank you, Joe. So this is just a brief case study of a patient we had the opportunity to see and work with the hospital, a rural hospital up in Alaska. He was a 78-year-old paraplegic that had a necrotic sacral pressure injury and newly diagnosed osteomyelitis. And they were really wanting to know, could we help them manage this patient virtually, or did they need to send him over 500 miles to a hospital that had access to a WOC nurse? So we were able to work with them, make recommendations, and we made recommendations that supported debridement, At the moment, it was an unstageable pressure injury, but you knew it was going to be a stage 4 with the osteomyelitis. It needed debridement, and then we recommended that to be followed up with negative pressure wound therapy. And then, of course, they were already addressing the infection control of the osteo that was already underway. We were able to do follow-up visits week 2 as the patient actually transitioned throughout their system as well. Week 2, it was an evident stage 4 with the tunneling and undermining that we helped support the recommendations and how to use, let's say like white foam and the negative pressure wound therapy, and really continued to promote that wound healing. And then we followed up finally week 8, noted that the wound was fully granulating. We were able to recommend that the negative pressure wound therapy be discontinued and make recommendations for advanced wound care at a much decreased frequency as he was returning home to be in the care of his family. So the outcomes of that is that we were able to be a part of this and observe the full healing progression, and keep the patient in his community with his family being able to visit versus he would have been truly isolated and alone if he was shipped over 500 miles. It avoided, the Medivac cost of transfer for this patient, which would have been over $80,000. And it preserved the revenue for that hospital, for this rural hospital, which was about over $1,900 a day. So the key takeaway was really that telehealth delivers that specialist care to rural and critical access hospitals that can support improving outcomes, lowering the cost, maintaining their patients, and supporting that local care delivery. Certainly drove that patient satisfaction to stay local and be able to have that family support as well.
Great. And now I want to turn it over to Mike Scribner, and we're super excited to work with Mike and his team because we believe that really getting into the data and looking at the actual data for a facility or a FQHC or really can highlight some of the hidden opportunities. So, Mike, would love for you to take it over.
Yeah, no doubt, Joe. And I guess our first point was to kind of look at, well, from a rural, our client base tends to be very rural Georgia, and there's obviously databases that are there for us to look at the relative volumes that come to the rural hospitals versus what goes to the urban hospitals. Well, if you sort of take that data and sort of carve it up with between those that have a wound care ostomy diagnosis versus not, you find that, and this is pretty typical of a lot of our hospitals. This is a county with a critical access hospital in it, where if it's not a wound care related diagnosis, they capture about 40% of that volume. There's a lot of it that our little hospitals can't do in the first place, and you would expect to outmigrate to the tertiary, quaternary facilities that are around. But the gap between not wound care related diagnoses and wound care was far more dramatic than I was thinking when we were coming into this. And you'll see in just a second, the gap is it's somewhat pronounced with ER cases themselves. And I should have even put that slide in here, but it's very much pronounced as it relates to follow-up care and then the inpatient and swing bed care, that care is solved. It's not retained in the local community, and it ends up moving over to the next largest facility out there. Go down to the next slide. So when you try to equate that to some level of net revenue that might be, again, everything aside, everything that you just heard relative to the benefits to the patient, benefits in the community, that this should hit everybody's china in terms of community health needs assessments. But just from a straight financial perspective, this hospital, this critical access hospital, the number of patients that had a wound care diagnosis is not terribly significant. This was the volume that actually did come to them, but the associated net revenue was pretty significant. And so those 171 patients generated over $900,000 in net revenue. Now, granted, this is a little bit bigger, quote unquote, rural county and rural critical access hospital than is our typical, but it's a fairly significant value per patient that would be, could be retained in their case is being retained by some of the services that they're providing. But as you look at it on the next slide, there's, if you kind of think about it in two kind of hunks, that one of them is we got the ER visit, but we didn't get the follow-up care, which in this hospital's case, they got about 45% of the ER visits that had a wound care diagnosis versus about 65, 70% of the total. But as it related to the follow-up care after an emergency room visit, that gap grew to 6 times more out-migration. And so in this case, if they were able to just retain half that out-migrating follow-up care, that that number of patients would generate another $275,000 of net revenue. Now, granted, there's a little bit of cost, but for the most part, we find that the rural hospitals, that the incremental cost per patient on an inpatient or swing bed setting is not substantial until you're adjusting nurse staffing. And so, with the education, you could retain more of the patients without just a whole lot of incremental cost with that. And then kind of pivot that same concept and move to the next slide. Now we're talking about, I didn't retain the ER visit in the first place because there was some perception that we either couldn't care for it, care for the patient, lack of education with our staff. We felt the need to transfer the patient on to the next biggest facility for the ER, or just the community understanding that because we don't have that capability in house, if they have that kind of issue, they're automatically going to the next facility. And that ER visit plus the follow-up care from there, if only 15% of that was captured and redirected, that's a $400,000 net revenue improvement to the hospital, and in that case to a hospital. Now, obviously, thinking about it, this is from the perspective of a hospital. From an FQ perspective, other rural practices, obviously, there's opportunity there as well. But we have certainly had the comparative database to use in this case. So I don't think there's any question that there's both a clinical argument to be made as well as a financial argument to be made that the vast majority of this care is making its way to the larger markets, and with proper education could be retained locally, and is a pretty significant opportunity. In this hospital's case, those three numbers are sort of additive. It's about $1.5 million, $1.6 million product line per se. And again, granted, a little bit bigger county, but fairly substantial net revenue at play. Joe?
Yeah, great, Mike. Thank you so much. This data is, to me, pretty compelling. And certainly, if anyone on the call has questions, please enter them, and then we'll open up the mic also. But Mike, do you also see some opportunities or implications? Maybe if you could dig a little more into maybe the FQHC opportunity that you see. And I know we've talked a lot about, kind of the diabetic management, as well as one out of every 4 diabetics gets a diabetic foot ulcer, and then 1 out of 4 of those has an amputation. So that whole management piece, but then also kind of the implications for some of the ACOs and other value-based arrangements. Any thoughts or comments there?
No doubt. That's a really great angle to be thinking about. None of this is really from the perspective of improvement of the total cost of care and generating shared savings in ACOs and the other value-based stuff. Now, granted, from a rural perspective, some of the non-traditional Medicare pieces of that are not quite as well ingrained in the market to have that financial opportunity be fully available, but it's definitely coming. And so your point is valid that if the difference between untreated diabetic patients and the massive cost of that versus well treated is, I don't have that number in front of me, but it's a lot of money. And so improving that does open up those opportunities. But just kind of back to the former question, in terms of rural providers, a lot of this, I kind of focused this on the hospital side on the inpatient swing bed obs care. There's a whole other side of this that's just the straight outpatient or should be in a performed in a clinic. All of those services, the vast majority of the encounter counts would be retained locally by the local practices, the FQs, all those kinds of things. And so there's, another level of opportunity on top of that, over above all the rest of this, to be captured locally.
Right. Yeah. Great points. Nationally, what we're seeing is, and it's not just in the larger, more urban markets, but also in some of the rural, is really kind of a migration to value-based contracting where, providers are taking on risk. Certainly in the ACO environment, that there's somewhat of that built into that. But and we talked to a number of payers about how they can manage some of these chronic wound patients. I mean, Medicare alone, there are about 10.5 million Medicare aged people with a chronic wound at a cost of upwards of 100 billion a year. Are you seeing anything in kind of the contracting side or the payer side that where we're seeing kind of a migration to more value-based opportunities?
Oh, definitely. It starts with
Yeah.
the Medicare Advantage plans, which are, obviously this range of diagnoses is more Medicare based. And so, yeah, definitely that's where the money is right now. There's been some adoption for the commercial plans pointed at a younger population, but yeah, there's definitely opportunity there. That is one level of it is just save money. There's no downside risk, and there's some gain sharing in it for folks. You move down to the other end of the spectrum, and there's some upside and downside risk associated with it. There's also a tremendous revenue opportunity associated with good care in this area.
Well, and also what we're seeing is obviously the focus on dual eligibles. Certainly working with the PACE organizations is a great opportunity for that. But, Medicaid, managed care, um, big opportunities on the diabetes management, and especially the prevention of the initial diabetic foot ulcer, but certainly preventing the recidivism around that is astronomical because of the age of the younger aged brittle diabetics or complex diabetics that are getting these diabetic foot ulcers. We're also seeing opportunities to collaborate with self-insured employer groups. I think that it's a much bigger, kind of prevalent problem than people realize, and typically do think of it as kind of a Medicare issue. But we're seeing diabetics as young as in their 30s and 40s with diabetic foot ulcers. So it's pretty amazing the shift in kind of the health economics of it all. Any other points, Mike, Alicia, before we kind of move on?
No, I think that's got it.
Awesome. So we would love, obviously, to open this up for questions. We are also available. There's a pretty wide variety of people on the call from multiple settings. So we would love to talk about your current wound and ostomy program and whether there are any opportunities to support your work. Certainly with Mike and his team, we'd love to dig into the data and see where there may be potential opportunities in the community. And just wanted to throw out too that sometimes, working with us, it's gotten a lot better since COVID. The fact that virtual care is a possibility, that you can actually do wound and ostomy care virtually. But we always find it very beneficial with our customers, potential customers, really, to provide a sample consult on maybe a difficult patient. So would love to chat with you, open it up for questions. All of this will be provided to you. This is our contact information that you'll see. I also and I'm not sure if there are any questions currently, but also wanted to um, include this as well. And Lloyd, if you have any comments on this, I know this is near and dear to your heart, but would love for you to comment if you want to. I think we've got
Yeah,
some time.
yeah, thanks for that. And if you do have questions, make sure that you unmute yourself. I know I ask everybody to mute, but just make sure you unmute yourself so we can hear your questions, or you can post a question in the chat. We'll be monitoring that. As far as funding goes, I think, and Joe, we talked about this a little bit. I shared with our telehealth work group meetings that we've been doing. We ourselves as the Southeastern Telehealth Resource Center, from tracking funding, we don't track foundation dollars because there's just so many foundations. I mean, that it would be absolutely difficult to track that. But there's a lot of funding opportunities that are available through foundation dollars. Those application processes tend to be a little more streamlined, little, I would say a lot less of a lift than, say, your HRSA grants that we reference up there. So that it's a great revenue stream if you have the opportunity. Those funds are typically going to be a little bit smaller funding, opportunities, but can be great seed money. So I would encourage you just to check health systems. I mean, there's so many foundations like, Atlanta. I was sharing this morning with our Florida work group in Atlanta. You have the Arthur Blank Foundation, and a lot of these foundations, will actually put money towards doing programs such as this. So, and then also, you look from a federal standpoint, you have your network planning grants. That's through HRSA, or whatever HRSA is going to be called moving forward, AHA, or whatever it is. You have a 1 year planning grant that they put funds towards. Typically, I think that funding cycle is about 100 grand. And so that's really funding that, funding for the planning of your program. And then you have a year planning, and then the network grants typically are larger fund. They're, like a 4 to 5 year funding cycle and about three and a half, $4 or $5 million. So the funding is a lot more. Those grants are a lot heavier lift. I don't know if many of you've ever applied for HRSA grants, but they're very tedious. There's a lot of information that you have to pull in. There's a lot of information that they request. And so those grants are typically a heavier lift. We, as the Telehealth Resource Center, wearing that hat, we're in the last year of funding. We are funded through HRSA. And so we applied for our grant, and I think it took us about 3 months, 3 to 4 months to actually write that grant. So it's they're very tedious. If they say 80 pages and you go 81 or 80 pages and a line over, it gets rejected. If they say it's due at 12 a.m. and you submit at 12:01, it gets rejected. So, much more tedious. USDA distance learning and telemedicine grants are a really great funding opportunity. They put a lot of money out. And really, what that is going to look like when we say distance learning and telemedicine, a consortium of providers who are wanting to do wound care, small rural hospitals, where you can do education. I mean, those type of things. There's so much that can be done. That USDA DLT grant, it's going to require a match, and it's only going to fund equipment. So these are great for people who want to beef up infrastructure, network infrastructure, such as router switches, servers, those type of things. These will fund, and then telehealth equipment. So carts, laptops. They're great funding opportunities as well. You can also look at some of your state fundings, and Joe did a good job of listing out some different, areas and possibilities that you can look at. All these are viable. And so there is funding to be had. It's just going out, finding the funding, and applying for those funding opportunities.
Great. Well, are there any questions that anyone has? We're a little ahead of time. We've got time for questions, or
Yeah,
we
plenty of
can
time.
wrap it up. And we also, we'll be sending this out, and feel free to obviously contact us with any questions.